Welcome to the Work Comp News and Views podcast, sponsored by Schlossberg and Umholtz, your go-to source for insights, strategies, and the latest updates in workers' compensation. Whether you're new to the field or a seasoned professional, we've got something for you. Don't forget to like, share, and subscribe, and or leave a comment. And now it's time to sit back, relax, and enjoy the Work Comp News and Views podcast, sponsored by Schlossberg and Umholtz. And good morning, good afternoon, and good evening, wherever you are, and welcome to another edition of the Work Comp News and Views podcast, sponsored by Schlossberg and Umholtz. My name is Steve Appell. I'm a hearing representative with the firm, and it's a pleasure to be with you once again. I was very fortunate to be able to interview Dr. George Balfour for today's podcast. Dr. George Balfour earned his medical degree from the Medical College of Wisconsin Medical School. He completed his internship and residency at Los Angeles County USC Medical Center in Los Angeles. Dr. Balfour completed his residency in orthopedics at Martin Luther King Jr. Medical Center in Willowbrook, California, and Fellowship of Surgery of the Hand at California Medical Center and Orthopedic Hospital, both in Los Angeles. Dr. Balfour practices orthopedic and hand surgery at several hospitals in the greater Los Angeles area and in the Antelope Valley north of Los Angeles. Dr. Balfour has teaching appointments as a clinical assistant and professor of orthopedic surgery and is an attending physician in hand surgery services at Martin Luther King Jr. General Hospital and the Charles R. Drew Medical School. Dr. Balfour is a member of several professional societies, including the American Academy of Orthopedic Surgery, the American Association of Hand Surgery, and the European Wrist Arthroscopy Association. So here's what we're going to do. This is a two-part interview. We're going to play the first part in just a moment, and then we're going to take a very short little break and talk about what's happening in workers' comp, some new stuff that hopefully interests you, and then we'll go back to part two of our interview. So without further ado, it's my pleasure to play the interview that I had the other day with Dr. George Balfour. And I'm on the phone with Dr. George Balfour, who was kind enough to join me for the podcast. Good morning, Doctor. How are you?
Good morning, sir. Good morning, Steve.
Doctor, I always figure in my interviews it's best to start from the beginning. I'm not aware, I know me, my family, a lot of people that I know, they never grow up saying they want to be in workers' compensation. People just kind of fall into it. Growing up, did you want to be in workers' compensation, or did you just kind of, like everybody else that I know, fall into it?
When I came out of fellowship, the people I went associated with were doing that, and I followed their lead.
Doctor, is there pressure from either side when evaluating the applicants and writing your reports to either be conservative or liberal?
Not anymore. No. It's pretty straightforward nowadays.
Can you talk about when it was before, what you experienced?
When I first came out, the applicant and defense bars were very adversarial, and they recruited physicians who would pamper to those points of view. Later laws changed that.
Yes, and I was going to mention 4906H, which of course says you're signing under penalty of perjury. You have not been provided or given any incentives or money or gifts or anything. I remember before that 4906H, which is originally 4906G, doctors got vacations and trips, and also doctors provided insurance companies with vacations, trips, and other stuff.
Yes, and even worse, before those laws in the late 1990s, early 2000s, I knew of people whose reports were entirely ghostwritten. In fact, the exams were ghostwritten. There was all kinds of games played in those days.
Like trips to Hawaii, trips to Las Vegas, etc.
I don't know about the trips,
Yeah.
but I do know that people were asked to it stayed in pediatric surgery, that the work they're doing was their own, because sometimes it wasn't.
Doctor, speaking of changes in the law and the reform, which the biggest one, of course, occurred about 19, 20 years ago, what changes in the law currently do you like and what changes do you not like and why?
What impacts my practice today more than anything else, it was the utilization review system. It was meant to bring consistency so that a patient would see Dr. A or B or C, and the results would be similar. And what ended up happening is that system became corrupt and became a system for rationing. And in the tertiary medicine, hand surgery, orthopedics, um, you have to fight for everything for the injured worker, way past what is reasonable. And worse, the when Schwarzenegger passed that law, he said it was people who are doing the reviewing should be in similar fields as the requesting surgeon, suggesting physician. Of course, that doesn't happen. We see nurses doing it, and people who don't have any interest signing off on it. It's a abusive system. People are harmed by it. I'm a bit of a up in arms because see so many people really harmed irreversibly as a consequence of the EUR abuse.
Doctor, the classic example that I've always used is you have an applicant admitted knee injury. He's on temporary disability. He's going to be certified. He's going to be certified for knee surgery, certified for a pre-op, certified for post-care physical therapy. You know he's going to be TD for about 6 to 9, 12 months after the surgery, and then utilization review denies a cane. I just don't understand it.
Nor do I. Worse, I see things like I saw a case where a physician wanted to do a test injection. The injection was about $60. And the EUR is maybe 250 to the insurance company, and they'll insist on spending 250 to deny the 60. It makes no sense.
Doctor, if you were the administrative director of workers' compensation or the head of the state legislature, what changes would you make to the system today?
I would. I've asked my state assemblyman that to write a letter to the division insisting that they actually enforce the present law the way it's written, that you are be neutral, that services be timely. And if they actually just enforce the law the way it's written in an honest manner, we would have a working system, which we don't.
You know, that brings up a great point. What can parties do, defendants and applicant attorneys, to make your job easier?
Uh, I would just insist that the reviewers, the providers of service simply look at the injured worker as a human being. I mean, most of these injured workers are working from paycheck to paycheck, and their attorneys are fighting against multi-billion dollar insurance companies. It's a very uneven playing field. And the consequences are delays, and at least in my business, excessive delay leads to poor results, and many things we do. If we could get to things timely and appropriately and provide just normal standard of care, we would get better results, and the human beings would not be harmed, which is what I think is going on.
You know, all of us have run into cases with applicants who have a frozen shoulder, an admitted shoulder injury. The shoulder is frozen. And my understanding, and again, you're the doctor, you're the expert, I'm not, is that you want to have immediate treatment for that frozen shoulder because even a couple of weeks of delay of treatment is going to make the permanent disability and the lasting impairment worse for the frozen shoulder.
Very true.
Utilization review has been around as optional, but of course, under the new laws, it is mandatory. And one of the reasons clearly that the legislature did that is to take the judges out of the picture of making findings regarding future medical care and the specific treatment. And that has been put in the hands of UR. But where I think the problem occurs is when you have an AME or a PQME, such as yourself, who recommends this, that, and the other, UR denies it. Is there something wrong with the way that part of the system works?
Oh, it's terrible. Unfortunately, what happens is the insurance company gets to pick the UR company, and there is very much an implied or suggested pressure on the UR fellow to say no. I mean, Appell approached me to do it, and they came very quickly that if you said yes too often, they dropped you. There's a that's denied. People will say that isn't true, but I see it. Um, the other thing we see is a nitpicky approach to diagnosis treatment. It's going to be hard for me to express, but um, making the diagnosis just is a subjective kind of thing. It takes history, physical examination, and testing. And for some things I do, I'm a hand surgeon, carpal tunnel surgery is the most common. They'll stick on one point, in this case, electromyographic testing. But in fact, that's controversial. There are lectures given in my field where electrodiagnostic testing is reliable. There's some controversy. There are other tests better. So if you look at the global thing, and you'll come up with an impression. If you're sticking on one point only, what you're diagnostic, you'll come up with erroneous diagnosis. And in fact, worse, we'll get people with a positive test and they don't have the condition because their history, physical examination doesn't fit. And it's not a black and white thing, but it's treated all too often by reviewers as black and white, leading to, in my opinion, error.
A good segue to what you were just talking about would be, of course, the credibility of the applicant. When you said sometimes it just doesn't fit, I'm assuming the credibility of the applicant has to have a major play in that type of finding. Doctor, how do you judge the credibility of an applicant when you're evaluating them?
Well, I'm going to take exception. You're talking about credibility implies people are lying to you. That isn't really what's going on. People are subjective. They're trying to describe to you what they're feeling or complaining about, and you have to interpret what they tell you. And sometimes their complaints don't fit the referred diagnosis. You have to be selective, particularly surgeons, you have to be very selective what they do. If you're selective and treat only the people who need the treatment, you'll have a high success rate. If you're sloppy in your diagnosis or lean only on one single test, let's say like your diagnostic, you're going to be doing erroneous surgery, which is why there's so much controversy in the field.
Doctor, how important is the joint AME letter and or the advocacy letters submitted by the parties to you? I've spoken to some doctors that say they don't even read them. What's your take on the advocacy and joint AME letters?
I find them very useful if they outline to me what they're really looking for, what they need. I can make sure to include that in my report. It's a nice, helpful tool. I appreciate it when I get it. Nothing worse than getting that very nice letter 2 days into the examination, which has happened to me. Getting that letter from both sides, appropriate and early, makes for a better report and a better, more helpful report for both parties.
Is there something in the letter that you are specifically looking for, and or is there stuff in the letter that you don't think is necessary?
Um, well, all too many of those letters are form letters. You hit two keys in the word processor, and that's not very helpful. When they actually do a good joint letter that tells us what their need, we can be more helpful.
And that is the end of part one of my two-part interview with Dr. George Balfour. You're dialed in to Work Comp News and Views, sponsored by Schlossberg and Umholtz. My name is Steve Appell. Please don't forget to share, like, and subscribe. And right now, before we go to part two, let's talk a little bit about what's happening in California workers' compensation. The Workers' Compensation Appeals Board continues to support liberal application of case and statutory law to injured workers statewide. The most notable case last year was Vigil, Vigil, and that is an in-bank decision. In Vigil versus the County of Kern, 89 CCC 686, the Workers' Compensation Appeals Board held that the combined values chart in the PDRs can be rebutted and the impairments may be added as the panel previously held in Kite. However, contrary to the guidance in Kite, seemingly requiring a synergistic effort between the impairments, the WCAB indicated the use of that term is not a magic word invoking addition of impairments, and instead laid out a new test for rebutting the CVC. Going forward, in order to rebut the CVC, the injured worker must satisfy either element of two-part test. One, if the injured worker proves the effects on ADLs caused by each body part rated do not overlap, they have successfully rebutted the use of the CVC and it need not be followed. Two, where the impairments do overlap, the injured worker must prove that the overlap increases or amplifies the impact on the overlapping ADLs. Furthermore, the WCAB emphasized that the physician must set forth a reasoned analysis explaining how and why synergistic ADL overlap exists. Where there is no overlap in the effects on ADLs, the PDRs must be rebutted and the impairment may be added versus combined on the CVC. Conversely, when the effect on ADLs do overlap, there must be substantial medical evidence on the synergistic effect of the multiple impairments on the applicant, meaning the physician must do more than simply state that there is synergy and must provide an explanation focusing on the effects of the impairment on ADLs. And once again, this is Vigil versus County of Kern, 2024, 89 CCC 686. It's an in-bank decision. Once again, you're dialed in to Work Comp News and Views, sponsored by Schlossberg and Umholtz. My name is Steve Appell. I'm a hearing representative with the firm, and now it's time for part two of my interview with Dr. George Balfour. Doctor, I don't think it's any secret that applicant attorneys and defense attorneys talk about the doctors. Do you talk to other doctors about the applicant and defense attorneys? And don't mention names, but I'm more concerned about the conversation.
Actually, not very often. I have not had long conversations with other physicians about specific attorneys. I'm going to even know some guys and meet them occasionally and say hello, but I don't think I've ever had a conversation with another physician about that particular attorney or other.
When talking about apportionment and causation, can you tell myself and the listeners what you think about and how you determine causation and apportionment?
You know, that is a field which is probably more than anything else that we do rather arbitrary. The truth be told, physicians, surgeons are really not trained in those areas. We're obligated to do it and give our best opinion, and we can give rough estimates. But that's an area where it's just wide open because there's no tools, not good guides for those areas.
And every once in a while, and I'm sure you've used this term, but when we have multiple injuries and different insurance companies and different mechanisms of injury, I inevitably once a year see the two words inextricably intertwined. Does that simply mean that the doctor doesn't know?
Sure. I mean, God, how the hell are we going to answer that? So it's a cop out phrase.
Doctor, how has technology affected your practice, both good and bad?
Huge. Sure. Huge. I mean, the things we do today, as standard of care, we didn't exist when I first came out. Um, you know about arthroscopy
Yep.
all the time. But when I started training, those things literally didn't exist, or they were so new. As if I told the young resident today the way we were doing it, they would look in amazement. That's what you did. I remember one of my a fellow that I had a swimming space for, and he was volunteering for the army. And he said, when you do semi-open, all the young residents would come over to watch because they didn't know how to do open procedures. All they knew was how to do it through a scope. Radical change. I remember when we started using ultrasound in hand surgery. It was revolutionary. What are you guys doing? You're insane. Now it's all the time.
You know,
Uh,
speaking
but
speaking of that, what's the difference between ultrasound treatment and radio frequency treatment?
treatments,
Treatments, yes.
um, they're really totally different. Ultrasound literally means high frequency sound. Radio frequency, they're obviously they're using radio waves. I don't use that particular technology, and I really can't answer the question. But they're two different kinds of energy.
Wasn't it originally developed to break up like kidney stones or something like that? And now in workers' comp they use it to break up scarring tissue, or am I confusing it with something?
Um, lithotripsy is the first version I heard of when they were breaking up kidney stones. I don't, and I see people use it. I've never used it myself, so I'm talking out of ignorance on that particular topic.
Doctor, when it comes to workers' compensation, what makes a good doctor and what makes not so good a doctor?
Well, I have a very strong opinion. Remember, my old faculty said, "Doctor, first you have to be a doctor. First, you have to be a doctor. You have to use your basic tools. Listen to the patient. Do a list. Take a thorough history. Take a thorough physical examination. Analyze the data and give your best opinion. It's that simple. But you don't take corners. And then, and you have to always be thinking of other diagnosis. I had a very clear family member who was treated for back pain by a pain doctor and who didn't much too late do an MRI and missed the pancreatic cancer that ultimately killed her. And I've been upset by that for years.
We spoke about the joint AME letters and the advocacy letters earlier. Inevitably, they all contain something to the effect of, do you agree with the treatment that has happened so far? And occasionally, do you agree with another's doctor's opinions? How comfortable are you when asked to agree or disagree on another doctor's opinions?
Somebody, it is awkward. If somebody's way off in left field, I'll say I disagree. But if they fall within a reasonable range, I hate to be critical. I'd rather give my own opinion, but I avoid being negatively critical about the next guy.
When it comes to objective and subjective factors, clearly an MRI is an objective factor. Arguably, an EMG nerve conduction study is an objective factor. But when it comes to the range of motion test, that clearly involves whether or not the applicant is giving a full maximum effort. Is the range of motion test really an objective factor?
It is objective, although I will tell you, when you say an MRI is objective, it has a positive and negative error rate. The MRI is not universally accurate. There sometimes say something isn't there and it's there, or something is there and it isn't. The same thing is true of electric diagnostic testing. Neither are absolutely objective. They're interpretive. And the same thing's true with range of motion. You can, but when a patient is being trying to fake, and that it does on rare occasion happen, you can feel it. Range of motion is as objective as the other test you mentioned.
What about the grip test, the grip strength test?
If you do it right, that's pretty objective. If you don't, there's just two simple ones. But do repetitive until you get a flat, consistent curve. It's pretty objective.
And, Doctor, in preparing this interview, the first question I thought of is going to be the last question, and I'm going to give it to you right now. When the parties request your deposition, what do you like, what do you not like about being deposed by the parties?
For the most part, when you're as a physician, you're sort of a neutral party to the deposition, and I find it kind of entertaining. Just give your honest opinion and let the chips fall where they may.
My father, who started in workers' comp literally 60 years ago, told me, and I'll never forget, that if you want to change a doctor's mind, there's two ways to do it. One is to give the doctor new information, and then, of course, the hypotheticals. I suspect you are receptive to getting new information, but how do you feel about those doggone hypotheticals?
I really don't. I don't know. Again, strange enough, I don't think that comes up to me very often.
All right. Well, Doctor, thank you very much to coming on to Work Comp News and Views. I really appreciate it. You've been very kind. Thank you so much.
Thank you for having me.
And with that, we are done. Much thanks to Dr. George Balfour for coming on the Work Comp News and Views podcast, sponsored by Schlossberg and Umholtz. My name is Steve Appell. I am a hearing representative with the firm. And if you like what you heard, please do not forget to like, share, and subscribe. We will look forward to seeing you on our next podcast. And thank you for listening to Work Comp News and Views, sponsored by Schlossberg and Umholtz. My name is Steve Appell. You've been listening to the Work Comp News and Views podcast, sponsored by Schlossberg and Umholtz. The opinions expressed on Work Comp News and Views are for entertainment purposes only and not to be considered legal advice. Don't forget to like, share, and subscribe, and or leave a comment. Also, feel free to send an email directly to sappell@schlossberglaw.com. For Work Comp News and Views and Schlossberg and Umholtz, my name is Steve Appell, and thanks for listening.